what do we mean by value in healthcare for patients? So let me start with some egghead stuff, because that's what I do for a living. So some thoughts on this word. Healthcare leaders, it must have started with Booz Allen or McKinsey, who come up with this equation. How often have you seen this? Now, an egghead will immediately look at this and say, quality is multidimensional. How do you divide a vector by a number? Right? That's kind of difficult to do. So we prefer to use QALYs, quality-adjusted life years, which is taking a multidimensional vector of quality metrics and collapse them into a one-dimensional thing that doesn't really exist, but you can pretend it exists, and we do, much to the chagrin of all the device companies, etc. You can have a whole course around QALY about the statistics of how to do it, the psychology of how to retrieve the information, and the ethicist who says this thing stinks. But today I'll just assume this is a meaningful metric, quality-adjusted life year. The virtue of it is that if an intervention increases life expectancy but not quality of life, it will capture it. But if an intervention doesn't extend life expectancy but enhances the quality of life of every year yet to live, this metrics will capture it too. So it's quite a clever device. The real problem is how to actually measure it accurately. So let me, so the first problem that arises when you're a geek is that you have this thing called cost. I don't know why this doesn't obey me. And there's Newman's law. Does anyone here know what Newman's law is? It's a famous law. So it goes like this. Alfred E. Newman's cosmic healthcare law. One person's healthcare cost is another person's healthcare revenue. And that law makes me sort of wonder when these people, many of them positioned book, when you tell them, write down the word healthcare cost, they'll actually write revenue. It's instinctive to them. What do they think about monkeying with this denominator? Because presumably, with that healthcare is quality divided by cost, you could increase value by lowering cost. But that's kind of a nasty thing. How many on the supply side would actually want to increase value for patients by cutting their own revenue? Do you think Partners board meeting would be sitting there and saying, geez, how can we reduce revenue to enhance patient value? I was on Victor's board. I don't recall that meeting. Maybe that's the one I missed, where we said, how can we reduce revenue to enhance patient value? I'm sure they had it. It's, after all, Duke. But I missed that one. So the first thing is this thing. So when you ask an economist, how would you write that equation? It's net social value added by the health system to the country. And for some reason, in translating into another computer, it should say gross value added by healthcare to patients, that's the dark you can't see, minus the opportunity cost of those expenditures for society as a whole. And I'll come back to those opportunity costs a little bit later, because I used to never talk about this because I thought we had enough money and these opportunity costs were trivial. They no longer are trivial in America. We're really in a new age. And the other problem is, how do you actually put dollar values on value added to the patient? And that's actually something at some point we do have to talk about, because it is all about money in the end. It is all about money when you think of these opportunity costs. So economists have a very simple idea of value. Res tantum valet quantum vendi potest. A thing is worth what you can sell it for. We learned that in high school in Europe. Practically, this means the value of a thing is measured by the maximum bid price he or she is willing and able to pay for that thing. Which also means that the value of healthcare rises with the patient's ability to pay high prices for it. Now, if you can you imagine Paul Ryan going, or Newt Gingrich, new presidential candidate, going on the campaign trail saying, I believe the value of a stent, as you heard him on the board, is worth more if somebody makes $1 million a year than it is if somebody makes 20,000. I think a stent is worth more. He may think that, I don't know, but he would never say it. But that's what economics says. In fact, Victor made me put this slide back because he loved it. It's scientific. It has, remember, freshman economics, there's a demand curve supply where it cuts. Now, this green demand curve is actually, you should think of each point on it as a different human being and their maximum bid price for that thing that they, if push came to shove, how much would they be willing to pay? That is the demand curve, and these are all different people here. Now, price and value are not the same thing. Yeah, here we go. Price is value at the margin. The last buyer just breaks even on the value. The price they pay is just equal to the value. That's what economists say, and I'm not sure that you buy this. Who here actually thinks this is great? You don't. It's interesting because as a nation we behave exactly that way. They don't in Holland or Germany or Canada, but we do. When I addressed Trenton state legislators and I said, you are telling pediatricians in New Jersey, we pay $30 for a pediatric visit, Medicaid, and commercially it's $120. And I said, you are telling a pediatrician, if you apply your work and your skill to a poor kid from Trenton, that's worth $30. But if it's my own kid, it's worth $120. It's a valuation. You're signaling your kid is worth 4 times as much. And whether you like that or not, that's the signal you give, and the physicians have understood it because no pediatrician in Princeton takes Medicaid. Why should they? You told them it's worthless work or low-value work. And in fact, 40% of American physicians don't take Medicaid. This is a problem. But that's valuation. The American people have told physicians, if you do something for low-income people, it isn't worth as much. Your work isn't worth as much as when you do that to me. That's a national statement that we signal out there. We say people are created equal. I buy that as far as conception is concerned. It's roughly the same. But beyond that, there's no equality, not even in the value of an implanted device. So right away, this geek is up to his geister in an ethical swamp. Do you see why I worry about what do they actually mean by value? The next thing in this expression, we measure QALYs, not values. So we say if a procedure produces 3 QALYs per $1,000 expenditure, it produces more, quote, value than if it does only 1 QALY per 1,000. That I can buy, but it still begs the question, how much money is that 3 QALYs worth? Take Prilosec and Nexium. How much more is Nexium actually worth? It sells at close to 10 times the Prilosec price. Is it really? Does it produce that many QALYs that it would justify that difference, for example? And, you know, how much is a QALY worth? And does that, particularly when it's tax money, and if the patient is poor? I wrote a blog post where I said the idea that human life is priceless is romantic and silly. So I testified before Waxman's committee, I guess it was, and Congressman Gingrey from Georgia, MD, asked me, did you write this? I said, well, you just told me I wrote it. Yes, I did. And he said, well, how dare you tell me what my life is worth? And I said, but I never said what you should think your life is worth. I was talking about how much I would pay for your life, and it's finite. I said, I tell you, it's finite. And he was, he was muttering his German, thinking of another era. I said, no, it had nothing to do with that. You sent my son into combat without a flak jacket. Don't tell me you didn't put a price on his life. not enough flak jackets, right? And this kid out there in an unarmored Humvee without a flak jacket. How do you think I feel about that? And, you know, interestingly, he took the entire exchange out of the written record. It's not in there. But so, you know, I do think deeply about human value, and I thought my son's life was priced out rather poorly by the Congress and by the DOD. So to think about this issue now, what I'll do is I flip this ratio around the value proposition and get cost per quality. That's what we call the cost-effectiveness ratio. It's viewed a Nazi tool, but all you did is invert a little ratio. That's all I did. One can view this as the price the health system charges us to deliver a quality. It's a price. And so then I can draw a supply curve that tells me at what prices the health system is willing to sell me qualities. And that curve looks like this. So at the horizontal axis, I have additional qualities that you would be buying off the healthcare system. And up on the vertical axis, I have the price they charge you per quality. And some are cheap, immunization for kids, you know, cholesterol control, blood control. These are fairly cheap things. But when you come to Avastin and Erbitux, you'll be up in C and D. And so the real question the health system is posing this country, particularly in its fiscal straits, is, okay, guys, this is what we can do, given how sloppily you guys want to live. Where would you like to stop buying, right? And in this country, you can't even mention that question. But the Brits have said, NICE, this National Institute for Clinical Excellence, they haven't never written it down, but implicitly they use $50,000 as the cutoff.